Hey, this is Brooke, functional medicine dietitian specializing in fertility, and this is the Fertility Dietitian Podcast, where I help you uncover the barriers that are preventing you from optimizing your fertility and teach you how to work with your body to finally take home a healthy baby. Each week, I will be diving into different topics on fertility and sharing my perspective on physiology, metabolic health, nutrition, and lifestyle approaches that have helped hundreds of couples get pregnant even after years of heartache. My goal is to empower you with the knowledge you need to take back control of your fertility. Happy listening. If you've been trying to get pregnant, you've probably heard a lot of different things that sound urgent or scary or final or just questionable. Maybe you've heard that you're over 35, so make sure you don't wait. Or your AMH is low, so you absolutely need to go to IVF right away. Maybe you've heard that you're already, if you're already taking a prenatal, you're good. There's nothing else more we can do to support preconception. These statements get repeated so often that they start to feel like facts, but many of them are either very outdated, very misunderstood, or taken way out of context. So today, I want to walk you through some of the biggest fertility myths that won't go away and what the data and real clinical experience actually shows. Because when you understand what's true and what's not, you can stop making decisions from panic and start making them with clarity. So myth number 1 is that fertility falls off a cliff at 35. Let's start with this one because it's created a lot more anxiety than almost any other myth out there. You've probably heard that once you hit 35, your fertility just drops off dramatically. But here's what the data actually shows. Fertility does decline with age, but it's very gradual. It's much more of a slope, not a cliff. And in your 20s, your chance of conceiving each cycle is around 20%. And in your early 30s, it's around 15% per cycle. And then between 35 and 39, it's closer to 10%. So that's a decline, but it's not dramatic. It's not a big old free fall that people have really been led to believe. And here's what's even more important. The original narrative around the 35-year-old cliff came from historical population data, not modern fertility clinics. We're talking about birth records from centuries ago, before modern nutrition, before understanding hormones, before prenatal care. And yet somehow this idea has really stuck around and became a timeline that women are still making major life decisions around. Here's how I want you to think about this. Age matters, but the environment your eggs are developing in matters way more, okay? Inflammation, nutrient status, mitochondrial function, metabolic health, toxin exposure, those are all things that you have a big influence around. So instead of thinking I'm running out of time, I want you thinking, how can I improve the environment my eggs are maturing in right now? Because you can actually have better egg quality in your 30s and even your late 30s than you did in your 20s based on that environment that you're creating, which increases your chance of conception each cycle. Okay, let's talk about another myth. Your AMH tells you if you can get pregnant. This is one of the most misunderstood labs in fertility, AMHs. AMH measures a hormone that's produced by follicles that are maturing at a certain state. So they're almost like mid-development. Because if they're smaller, they don't produce AMH. And if they're larger, they also don't produce AMH. Okay. This lab is often thought of measuring ovarian reserve, but it's not a great lab for that. And it's also not a great lab for telling you anything about the quality of those eggs either. It does, however, give us information on how safe your body feels to support maturing follicles. So we know that when AMH is low, in my practice, I use it as a data point for where to look next. Okay. And I should also say that AMH has zero correlation with natural conception. It's really more correlated with how you are going to be responding to IVF, specifically a retrieval cycle and the stems that go along with that. So the hormones that are given to you to help mature multiple follicles. So if your body's already not feeling safe enough to mature follicles, you can imagine how hard it's going to be by adding in additional burden of those hormones and medications to get more eggs to mature more quickly. Okay. So I don't put a lot of weight on AMH for this reason. We put way more weight on how safe your body is feeling overall. And I also see AMH improve all of the time in practice when we focus on those safety factors and look at the body and fertility as a whole. And just taking a step back again to quality of eggs, AMH tells us nothing about that. And it's really the quality that determines whether an egg can actually be fertilized and become an embryo and be able to implant from there. Okay. There was a large study looking at women actively trying to conceive, and we do see that women with low AMH had a very similar chance of getting pregnant within a year compared to women with normal AMH levels. Okay, so that gives you a little bit of insight as to what AMH is potentially telling us. Not a heck of a lot, other than how you might respond to stems, right? Oh, it was never meant to be used as a prediction of your ability to conceive naturally. And what happens is when women get that number, unfortunately, they think their body is failing or you're running out of time. And it's just not true. Okay. So know that AMH is one data point. That doesn't mean a heck of a lot for natural conception. And we can actually see improve based on how safe your body is feeling, right? High AMH on the other side, I want to just share a quick note on this. So if you are seeing high AMH, it's likely because of inflammation, insulin resistance, or basically the body communicating that it is struggling to fully mature follicles. Okay, they're getting stuck in that mid stage of development. Okay, which does decrease egg quality there. So there's a lot that we can do to help support the opposite of that too. So high AMH or low AMH can be shifted based on metabolic support and overall how safe your body feels, essentially, to support reproduction. All right. So the number's not the full picture. Your biology is way more nuanced than AMH. Okay. So don't let that be a fear tactic for making big decisions on fertility. All right. So myth number 3, maybe you've heard that, you're taking a prenatal, any prenatal. And so that's good. You're covered for preconception care. This one is kind of tricky because it sounds responsible, right? You're adding in some support there. And yes, taking a prenatal is a good starting point, depending on the quality of that prenatal, of course. There's a really big difference in qualities because not all prenatals are created equal. Most are not designed for that preconception window, really. They're just a low quality multivitamin, unfortunately, without much evidence-based support around it. 2 to 3 months before ovulation or before trying to conceive is really when you want to be thinking very, very minimally about preconception care, because it takes an egg about 3 months to fully mature, or that is the window of maturation that we have the biggest impact on the quality of that egg that you will be ovulating. Okay. So that's really where nutrition has that direct impact, that 3 months before. If you've maybe not created the healthiest environment in your body, you want more time than that. Okay. You want several maturation cycles to see an even bigger significant impact on egg quality and overall reproductive environment too. So a few things to think about. We want to make sure that your prenatal has the appropriate types of nutrients in it. Many prenatals use folic acid, which your body has to convert into the active form. And a significant portion of the population does not actually convert it efficiently. And then there is a substrate that builds up, okay, or byproduct that builds up because it's not being converted efficiently. And that is essentially going to be inflammation. It's going to lead to more issues, right? So we want a active, easy to use version of folate, not folic acid. So methylfolate is one of those. Folinic acid is actually another one. That's super confusing, I know, but a form of methylfolate is typically going to be best because it's already in usable form. The kind that we find in food. Also, leafy greens and beans is where we get most of our folate in our diet. Most prenatals also don't contain any or enough of choline, which is really, really important for fertility and especially the early developmental stages of conception, but it's really helpful for egg quality along the way too. And we also need to think about many other minerals, omega-3s, antioxidants. So some of these we don't actually want inside of our prenatal. Iron, for instance, I would never recommend a prenatal that has iron already in it because not only does it compete with calcium, which are typically in prenatals for a good reason, but not everybody should be supplementing iron because there is a lot of nuance around how your body's able to use it. We actually make all of the iron that we need every day. If that iron is already being dumped into your tissues and creating more inflammation, also supplementing iron is not going to do you any favor. Okay. And then omega-3s, also, I don't recommend that being incorporated into the multi version of a prenatal because it's not stable, oxidizes. You want it separate. You want it to be able to be refrigerated. So there's a lot to think about with prenatals. And I do recommend taking one because we need to fill in the gaps of our modern diet, even if you are being really mindful of what you're eating and making your diet really nutrient rich. Filling in the gaps is still highly necessary, but don't assume that checking that box means you've fully, just grabbing a random prenatal off the shelf means that you've really fully checked that box essentially, or that there aren't other things that you need as an individual. Okay. So this is really where that specialization comes in and matters big time too. As far as some prenatals that I recommend, I am a big fan of very comprehensive prenatals that have their nutrients in the appropriate forms. This includes Fullwell Fertility, Women's Prenatal, as well as Needed, as well as FIGs, really excellent, high quality prenatals that are going to help fill in those gaps much better than the vast majority of others on the market. I will link those in the show notes as well for you to refer back to. Another myth that I want to talk about is that infertility or struggling to conceive is a women's problem or the female side. This one needs to go far, far away. Male factor is involved in about half, if not more, of all infertility cases. Okay, so that's male factor being involved. So not necessarily solely being male factor, but it being a factor in conception. Yet the burden of testing and treatment, the emotional weight is typically just placed mostly on the woman. Standard semen analyses look at things like count, motility, and morphology, which is great. And a lot of times I don't even see morphology being looked at, but they also don't look at DNA fragmentation or oxidative stress or a deeper look at the actual quality of the sperm. So motility and morphology definitely give us insight, but that DNA fragmentation is going to be an even better look because we can see high DNA fragmentation, which is actual damage to the DNA being done, even if motility and count are looking good. Typically, we see morphology still being off with high DNA fragmentation. But I recommend looking at it so we have that full picture and know how to best support the quality of that sperm. Cannot tell you how many couples I've worked with where everything is really focused on the female partner, while a major piece of the puzzle was really the male side being completely unaddressed. Even though he did have a semen analysis done, those parameters were nowhere near optimal. They might have fallen into quote unquote normal. But those normal parameters on a semen analysis are really honestly outdated and not doing us any favors at all. So I have a full episode on this topic if you want to more information here, we'll link those episodes in the show notes also. But essentially, if you're trying to conceive, both partners need to be evaluated at the same depth, at the same level of importance, okay? Because it really does take two. All right, next myth. Myth number 5. Men don't have a biological clock. They actually do. It just hasn't been talked about in the same way, right? Because they don't ever stop producing sperm. But as men age, sperm DNA fragmentation tends to increase, and it becomes a lot harder to decrease into those optimal ranges. This can impact fertilization, embryo development, miscarriage risk. And here's the catch. A standard semen analysis can still look normal. So couples are told that everything's fine while there are underlying quality issues that were never tested for. We need to stop acting like male fertility is static. It is very responsive to lifestyle, nutrition, and age, just like for female fertility is. So as they age, they might need different types of support. And this is definitely what I see in practice as well. But if we don't know it's a concern to be addressed, it's often just pushed aside as a female issue, unfortunately. So again, I'll link deeper dive episodes, podcast episodes on sperm health that you can listen into too. I also have a male fertility mini course if you're interested in getting some more actionable things to get started with on the male side as well. Another myth is that you just need to relax and it will happen. You'll get pregnant. So I had to include this one because it's one of the most dismissive things that you could say to someone that's trying to conceive. Stress absolutely does matter, but not in the way that people think. Okay, so you didn't cause infertility by being stressed, and relaxing alone is not a good treatment plan. But what actually matters is how your body is responding to its environment. So we can have internal stress that is absolutely going to have a really big impact on how safe your body feels to nourish fertility and get pregnant and have that healthy baby. So chronic stress can impact things like ovulation and blood sugar, inflammation and hormone signaling. But the solution is not relaxing. It's supporting your nervous system, your sleep, your blood sugar, and your overall resilience. So we want to make sure that you're able to respond to the stressors better. So it's physiology and not just mindset in that aspect. And last but not least, another myth that we have to talk about is that egg freezing is an insurance policy. Egg freezing can be potentially a helpful tool, but it's certainly not a guarantee. Each egg that is frozen has a relatively low chance of becoming a live birth. That's why the number of eggs matters so much. Okay? At the egg at which those eggs are frozen matters. Freezing eggs at 38 means you are freezing 38-year-old eggs. We can definitely prep for this and improve outcomes a lot, but it does not pause the biological age of This doesn't mean that it might not be a right option for you, but it just means that you need to go into it with clear expectations and a strategy. So preconception prep for a retrieval for egg freezing is a really, really good idea. And we do know that embryos freeze better than eggs alone. So keep that in mind too. A lot of times we're freezing eggs because we haven't found the right partner, which makes sense. But as far as having realistic expectations, that's an important one to keep in mind as well. All right, so here's the truth. Fertility is not as simple as the headlines or social media tends to make it. It's not just one number, one test, one timeline. It's a reflection of your internal environment, and that environment is responsive. When you shift inflammation, when you support metabolism, optimize nutrients, and reduce hidden stressors, you change the conditions your body is working with. That's where your real power is. Not in chasing perfect numbers, but in understanding your body well enough to work with it, because your fertility is not fixed. It's very dynamic, and we can actually improve it as you age. And when you know what actually matters for you, you can stop guessing and start moving forward with a plan that makes sense for you and for your male partner. If you found this episode helpful, please share it. I hope to see you back next week. And as always, if you're looking for a deeper dive, one-on-one support, you know where to find me. Thank you for listening to this episode of the Fertility Dietitian Podcast. If you enjoyed it, please leave a review to let me know what topics you want more of or less of. If you want to keep learning, subscribe at Apple Podcasts, Spotify, or wherever you listen to podcasts. Check out my website for more info on my private coaching program, Master Your Fertility, or my membership community, Fertility Blueprint. And don't forget my digital store. Come say hi on YouTube and Instagram. See you in the next episode.